Good afternoon, everybody. First, I welcome you all to this joint webinar between General Practitioners Association and Jaslok Hospital. And my sincere thanks to Dr. Malav Jhala. He may not know me, but I know his even grandfather. He is Arvind Kaka's son. We used to call him Arvind Kaka. So anyway, so he is Darshan's son. That is my special attachment. But at the same time, I am thankful for you to agree to deliver this lecture at the very last moment. So our GPA remains indebted to you, Malav. Thank you. Thank you again. Now may I request Dr. Atul Doshi to take care of the proceedings.
Thank you, sir, for your kind words. And today's chairperson is our senior most family physician, Dr. Mahmood A. Merchant, practicing since last 54 years. Past president of GPA, now scientific convener, recipient of Dr. L.V. Kripalani Lifetime Achievement Award, presented many papers in GPA conference, received several prizes. Only general practitioner who has taught ECG to more than 5,000 doctors in Mumbai, Thane, Pune. Over to you, sir. Thank you.
Thank you, Atul Bhai. Thank you very much for your kind words. Now, before I introduce Dr. Malav Jhala, I must congratulate Dr. Dolakia for selecting such a fantastic topic. And every GP should know about this particular topic. And I'm sure that most of the GPs must be having the ECG machine. But even if they don't have ECG machine, the symptoms are important. For example, if somebody has suddenly got a syncope and you examine the patient, the pulse may be slow. And if you take a cardiogram, the pulse may be slow, suddenly it go fast. What is known as sixth sinus syndrome. Now, in such condition, our Dr. Jhala will come into picture and he will put a pacemaker. Then similarly, if you see cases where you will see a second degree heart block, Morbis type 2 or a complete heart block, in such cases also you require a pacemaker. Now there are some people who complain of palpitation, and when you examine, suddenly palpitation disappear. And when you take an ECG, you see a short PR interval with WPW syndrome, with delta waves. So if you see a short PR interval with the delta waves, that is WPW syndrome giving rise to palpitation or arrhythmia or what is known as supraventricular tachycardia, and Dr. Jhala will take over for the pacemaking. Same thing happen if the short PR interval is there and there is no delta wave, and still the person complain of the palpitation, and that is called LGL syndrome. In such condition also, Dr. Jhala will put the pacemaker. There are people who keep on complaining of so many things, like suppose if you take an ECG and you see a trigeminal or you see a ventricular tachycardia suddenly disappear. And even on Holter, if you see a ventricular tachycardia coming, then of course Dr. Jhala will come into picture and he will put, what is known as AICD. So here is Dr. Malav Jhala, who is now this is a super specialty in cardiology, what is known as arrhythmia associate. So this is one particular branch of cardiology which is very important for GPs to learn. And Dr. Malav Jhala, who has done his MBBS from Somaiya Medical College, and he came first in his final MBBS. And then he went to the Ashwini Hospital at Kulaba, where he did his MD in medicine. And after that, he came to my alma mater, Govardhan Sundardas Medical College, KM Hospital, and he did his DM cardiology from KM. And he was associated, as the associate fellow, physiology fellowship. He did it in he was in Asian Heart before, but he did his fellowship from Hyderabad, if I am not mistaken, sir, under Dr. Narsima. And he has got many presentations, many publications. I won't go into detail and come in the way of his talking. And and of course, his main interest is in photography. He's a karate, the champion black belt, and he's interested in photography. So please, sir, take over of your topic on various pacemaker, arrhythmias, and whatever you want to talk about electrophysiology. He's attached to Lilavati Hospital. He's attached to Critic Care. He's attached to BACS Hospital. Am I right, sir? Yeah.
Yes, sir.
Take over, sir. Thank you.
Thank you. Thank you, sirs, for a very exhaustive introduction. I am really honored. And to keep this talk really simple, I thought that today we will discuss on an approach to bradycardias, and it will be a more of a clinical approach. So I will share my presentation just now, and we'll straight away start with our talk so that we don't waste any time. So yeah, so can you all see the slides?
Yeah,
Yes, sir, we can
bradycardia.
see. Yeah.
Okay,
Right
okay.
on is seen. Yeah.
Correct. So I think after a very good introduction and a good discussion on this at the beginning of the talk itself, I think my job has been made very easy. Uh, if we go on to speak in electrophysiology during my training and then subsequently it can take one full day. That's not our aim. I wish to finish it as early as possible, keep it as concise as possible so that we can have much more time for a joint discussion. When I trained in cardiology, I came in an era when angioplasties were what we were taught in our second year, and angiographies were what was given to us as the first procedure. Now that makes this line a very surgical line in my personal view, and it is a good thing, but it is also a bad thing because the essence of medicine is lost as and when you start doing only interventions. And that's where electrophysiology was always something which was close to my heart, not only because I've seen it in real person and I've been associated with my father and their colleagues doing it, but also when I was studying, I find that decision making in arrhythmias is much more clinical than most of the topics in cardiology and medicine likewise. And that is what I think is the crux of my talk. I have divided my talk in such a way that there will be a few slides on the basic anatomy and physiology of the conduction system, and then a very broad approach in your day-to-day life about bradycardias and how you should deal with them. Because as a super specialist, I invariably will get a referred patient, but the thing is that the front line continues to remain physicians, general physicians, surgeons. You people are the ones who would have a patient walking into uh, your clinic, your hospital, and without a label. When I get it, I would be a little biased because some workup would have happened, certain mistakes would have already happened, which in your place I would have done much more in terms of diagnosing. And that's why it's easier for me to tell you. But I believe after this talk, I think we will be able to have a very good outlook towards these episodes of bradycardia syncope that a lot of patients today come, not only old, but the young, fit ones also. So again, I have nothing to declare. And on a note, at the end of this presentation, will we be able to answer this bottom line that whether I can prescribe a pacemaker to all my patients of bradycardias? To cut this long presentation short, I would say not always. And I think I would just close this presentation here. So now let's see why is it that you can't always be very certain in a lot of patients that you need a pacemaker, and there is a lot of digging in that we have to do. So to begin with the conduction system anatomy, so just a little refresher course. If we are to just see, then the sinoatrial node is an epicardial structure which is located at the SVC RA junction on the superior aspect. And from there, that's the primary pacemaker of the heart, and that's how the entire cardiac conduction system initiates, and that's how it has the maximum firing in mechanism, and it overtakes all other pacemaking circuits in the heart. So that's your sinoatrial node. And then you have the AV node, which essentially is at the level of the AV grooves or the atrioventricular grooves. It can be approached anatomically. It can be seen. There are two parts to it. The compact AV node, which is located a little higher up and can be seen from the right atrium near the tricuspid wall or the so-called triangle of Koch. And then you have a penetrating bundle of his, which is the penetrating portion of the AV node. As you can see, it is sandwiched in the membranous septum. And mind you, this is the reason why whenever we do the TAVI procedures nowadays, or surgical aortic valve procedures previously, it was the penetrating portion of the AV node which would get sandwiched and invariably lead to an AV block. And that's the reason today, I'm sure most of your patients who have undergone TAVI or you have been associated with a TAVI, this discussion of a pacemaker post-implant always comes into the talk of the referring cardiologist. So coming down, you have the bundle branches, the right and left, and then you have the Purkinje fibers distally. So to maintain the kind of AV synchrony, you have the AV the interatrial bundles on the right side, and to maintain a biatrial synchrony, you have something called as the Bachmann bundle. Now, mind you, these atrial bundles are not really conduction tissues. They are just atrial myocardial cells which have this conduction potential. So they are not necessarily anatomical structures, so to speak, and they just have certain properties. So why is it that these conduction system fibers take over the conduction, myocardial conduction, and not the normal myocardium? So the answer lies in this interesting cartoon that we have here, where we see the pacemaker action potential curves of the sinoatrial nodes and the AV nodes. Now, what is important is that the so-called resting membrane potential or the excitability of these cells is much quicker and they're much more easily excitable than the myocardium. So on top is the classical pacemaker action potential strength duration curve, which you can see, which is has three phases only, and it has a higher a lower resting membrane potential, more excitable form, versus the lower one, which is your true myocardial potential action potential curve, which has a much lower resting membrane potential. And the SA node has the most excitable tissue. AV node is the next, and so on and so forth. So whenever the particular conduction system fails, the next one takes over, albeit at a lower rate. And that's why traditionally we have this when we didn't have ECGs or when we didn't have access to it, looking at your basal pulse rate, sometimes, not always, you can make a rough judgment that what level of block is there. So for example, if the rate is 22, it is definitely that the conduction system is diseased and that there is an infra or an intra AV nodal problem definitely there if it persists for long. So these are the nuances that we have, and just I believe a little dry part of the presentation, but it is important for us to understand so that we know why these mechanisms are there and how they fail and how we decide on a patient requiring a pacemaker or not. So just to summarize, if you have a problem which is above the AV node, it's called the sinus node dysfunction. You can have fast rates, slow rates, it doesn't matter, but it's a sinus node. You have the AV node which takes over. So generally you have some time to take a decision. Infranodal or intra-AV nodal problems, patients may come with a dramatic presentation. It could be a persistent AV block or a second degree or a complete AV block or a complete heart block, where the decision is almost certain that the patient is going to need a pacemaker unless he has some significantly reversible condition available. So how we would really approach is, if the patient comes to you with persistent bradycardia, ECG showing bradycardia, generally you're dealing with either a sinus node disease or an AV nodal block. And that's one aspect of it. But a lot of patients today, and I believe most of you would be having unanswered questions about this, that a patient has come with a pre-syncope or a syncope, he's come to my clinic, the ECG is not so bad, it's a sinus rate of 60. What do I do? How do I really work this patient up? So I would say that this is the subset of patients, major chunk, where you need to do some sort of rhythm monitoring, something like a Holter or a patch, and as much as possible, based on the clinical documentation, patient has multiple episodes in a short span, a 3-day or a 5-day Holter should be enough. But at least a week Holter is required for patients who have, say, disjointed symptoms once in a week, once in 15 days. So 1 week Holter tells you what's happening to the heart, even if the patient's not symptomatic. So once you document the arrhythmia, you can then subsequently decide whether it's an intrinsic problem. You have a paroxysmal AV block. That means the AV block comes and goes. You have paroxysmal sinus node dysfunction, or patient has atrial fibrillation with a slow ventricular rate, which are all related to the conduction system, or the patient has a bundle branch block, like a left bundle branch block, or sometimes it's a left bundle branch, sometimes it's a right bundle branch block, so-called alternating bundle branch blocks, which are harbingers that the conduction system is diseased and is likely to give way any moment. So important is that your decision is based significantly on the patient history. And that's why it's a very clinical decision for you. And you need to sit with the patient, understand whether it's a classic cardiac syncope or a seizure. A typical cardiac syncope patient would be sitting and going down on the floor, becoming absolutely fine immediately. No post-ictal deficit, no bladder bowel incontinence, no drowsiness after that. That's a very typical cardiac syncope, and that will seldom be a neurological problem. So it's important to sit with the patient to decide if you don't have a documented arrhythmia. Now, there is a sizable population of young, fit individuals or the so-called marathoners who will come with a classic reflex syncope. They're standing in the hot sun, go kaput on the floor, or they have a vomiting episode, they go kaput, or they have some stress and they go kaput, some pain and they go kaput. So these are the reflex syncope patients where the vasovagal effects are very high and there is a carotid sinus hypersensitivity, which may need a specific tilt test evaluation. Again, this is a if you have a normal patient with a recurrent syncope, no documented bradycardias, and very typical situations where he is doing it or becoming unconscious, then that's a reflex syncope. So broadly speaking, you have either you have manifest AV blocks or sinus node dysfunction, or you have paroxysmal, or you have diseased conduction system in the form of bundle branch blocks, or you have extrinsic causes like a reflex syncope, and you have maybe a 1% patients who have only unexplained syncope. So this is what we have as the pathological variants. Now, not all low heart rates are bad. You have an athlete or you have a dancer, their rates are going to remain 50, maybe even 49, but there is every P followed by that of QRS. It's called sinus bradycardia. You can live with it if the patient is asymptomatic. You can have a first degree AV block with a PR interval of about 200 and patient being absolutely fine and in his 80s. That's fine. It doesn't need to be treated just because he has a first degree AV block. Again, if he doesn't have any symptoms. And some of the elderly patients or some of the patients may have a unnoticed first degree AV, second degree type 1 AV block called the Wenke-Back phenomena, which we'll discuss subsequently. If they are asymptomatic and it was a bystander finding, we would leave it. Some patients may need, so that we'll discuss in detail later. So this is what we discussed. And of course, as I told you why it was so clinical, I'll just quickly just show you that these are the number of drugs that can cause bradycardia. Almost every drug that we use in clinical practice is supposed to cause. Not only that, a lot of other extrinsic and intrinsic causes like NMI, cardiomyopathies, genetic problems, infiltrative cardiomyopathies like sarcoid, amyloid, so in many infectious diseases, a lot of surgeries like bypass, valvular heart surgeries, a lot of metabolic conditions like severe hypothyroidism, or a sick patient with hypokalemia, or acidosis. So there is a lot of extrinsic causes which can cause bradycardias which are reversible. But one understanding that we have as electrophysiologists is why is it that many times you have a patient who has a potassium of, say, for example, 6 and he's doing absolutely fine, and the other one comes with a AV block or hypokalemia of 2.8 and goes into a first degree AV block or a CHP. Now why is it that this one's causing it? Now many times there are drug interactions, they are on antifungals, they are sick, septic, and they have an electrolyte, so a lot of hits to the conduction system. with a baseline disease conduction system. So many times the disease conduction system plays a role in deciding whether you're tipping over the patient to a complete heart block or not. So once you have a patient who doesn't have all this, we don't really bother with the extrinsic causes. This is generally for patients who are in the hospital, in the ICUs, or being referred or being treated for something else and are referred with a bradycardia episode. So again, this is just what we discussed. It's a very what shall I say? It's a very comprehensive diagnosis that we have to do. Just a low heart rate, but a good physical examination, good ECG, rhythm monitoring, and a good assessment of the heart in terms of an echo, sometimes an MRI or a PET to decide on the etiology. So this is how we would proceed with a bradycardia patient once you know that the patient has a bradycardia. Whether you go to the next step, so I think a basic ECG and a Holter and an echo has become a standard of care. Now, if you suspect that there is something wrong and he's a younger patient, he's not fitting into typical degenerative AV block kind of a subset, you need to look at infiltrative cardiomyopathies like sarcoidosis. Sarcoidosis is a group of infiltrative cardiomyopathies. It used to be thought that it is associated with tuberculosis. Now we know it's a separate entity. It requires specific targeted blood tests like an ACE level or sometimes a MAN2 test, a basic echo where you look at the basal septum for thinning, and a good cardiac PET to look for uptake in these regions. So again, why we are talking of sarcoidosis, we used to think that it is a Western phenomena. It is no longer. So in case you go into the net and you search for Dr. Narasimhan's paper on sarcoidosis, he's done a lot of work on sarcoidosis in India, and we have made a lot of clinical judgments. One of his findings was that the dental enamel, the dental procedures where they used to use fillings would cause a monocyte macrophage activation response and cause infiltrative cardiomyopathy. That was one of his very significant findings. So imagine something as simple as a root canal or a dental seal can cause in predisposed subjects AV block or LV dysfunction. So that's why it's important to understand not in the all subset of patients whom you expect. So an elderly patient with a CHB, it's fine. That's expected. What happens to the younger ones? Why are they becoming like that? A sizable population will have either inherited forms of cardiomyopathies or AV blocks, or they may also present with a vagal response, and where you have typical personality, really anxious people, really exercise, what shall I say, exercise freaks who come to you with a very basal heart rate. So just a good 1 minute pulse examination, just a simple TMT, and you will come to know that his basal heart rates are remaining low, and he's a gymmer and all that. It many times, and a conscious reference for a tilt table test tells you a lot of things. So that's how I wouldn't go into the details that I've shown here. Just go with your clinical judgment, and that's how we decide. So it's pretty logical based on what you look at. If it's a usual case, you just stop here, put a pacemaker, depending on the case maybe. But it's something out of the ordinary. You need to now today give an answer as to why this patient's got bradycardia. Again, if the patient's asymptomatic, you can take your time deciding. But what happens is many times you will get a reference for an acute bradycardia with a syncope, head injury, patients come to you, come to the ER, what do you do? So if the patient's hemodynamically unstable, regardless of whether it's a reversible or an irreversible cause, I would say that you need to restore the rhythm quickly. The best thing to do at that point in time, till you get your things in order, get your cardiologist to come, or even if you don't have a capability of putting a temporary pacemaker up front, is to start maybe an isoprenaline drip in the ER itself with monitoring. Try to get the ventricular rates up a little and get a 12 lead ECG before you do that, so that we know what the rhythm is. And then quickly, if the patient's unstable, get a temporary wire in, get the rhythm stabilized. Then you can always take a call what needs to be done, whether you need to really continue the temporary pacing. Was it hypokalemia? Was it something else? Metabolic things, drugs, everything can be found out. So we can always keep the lower rate of the temporary pacemaker as low as possible so that the internal rates come up. So it's a It's actually a wrong feeling that if you put a patient on a temporary, he will always become dependent. That's not the case. If the patient's conduction system is really sick, then they will become dependent, which way they would, and would require a permanent pacemaker. Again, whether you can offer them a transcutaneous pacing or not, I'm not a very good fan of transcutaneous pacing. It doesn't always work, but hey, anything works as long as you're trying to save the patient from something and you have it. Why not use it? So transcutaneous pacemakers are standard defibrillators which are capable of giving the pacing through the patches that are connected. They are available in most of the hospitals in Mumbai today. So now we come to this one subset, that is the sick sinus. I'm going to be dwelling a little more in this subset because according to me, this is a very commonly seen entity, and there are a lot of unanswered questions as to which ones do we put a pacemaker and which ones we don't. And I'm sure you are going to be at times exasperated when we tell you, look, this patient doesn't need a pacemaker, and you would have counseled them otherwise. So I think we are going to spend this time, because AV blocks, most of the answers we know, but sick sinus syndrome is something which is a little interesting and much more common. So of course, it's the inability of the sinoatrial node in producing an adequate heart rate that meets the physiological needs of an individual. And this, mind you, is the definition provided by the AHA task force, and it's an accepted definition. So it's as vague as the disease. It's predominantly found in the elderly and those with comorbidities. There is a very strong association with sleep apnea and sleep disordered breathing. You need two things for sure. You need to have symptoms and you need to have bradycardia ECG, and both have to collaborate. If the patient's having symptoms and that sick sinus syndrome ECG available at the same time, there has to be a symptom rhythm correlation. It's very important to decide whether the patient needs a pacemaker or not. And what are the symptoms? It could be syncope, if you're lucky. If not, then it could be just fatigue, exercise intolerance, or just mental slowing for which there is no other cause. He's been evaluated, ruled out, he's just confused or a little bit off, and patient's family says he's doing so well, he's such an active person, but he's a little confused nowadays. And that should be a trigger for you to look for this entity. Again, permanent pacing is only in patients where you have established that sick sinus syndrome is causing the symptoms. Because sick sinus syndrome asymptomatic is found in at least 20% of the population who are elderly. That's a very sizable sample. So again, as I told you, prevalence rate of symptomatic sick sinus is 1 in per 1,000. It is known to increase with age. There is no gender bias. And the most common form is the so-called tachybrady syndrome or the tachycardia-bradycardia syndrome. I'm sure sick sinus syndrome has been a bone of contention for most of us. So I'll just try to make it a little simple for you. Mind you, this is a little busy slide, but bear with me. We have certain definitions that we use. One is, of course, the sinus bradycardia. Whenever we say sinus bradycardia, the sinus rates are below 50. Then you have something called as a sinus exit block. So there is a problem of propagation of the P wave from the sinus node either inside it or into the atrium. Again, the first degree, second degree, and third degree of sinus exit block are very similar to the AV block. So the first degree problem is conduction slowing within the sinoatrial node itself. Seldom seen on an ECG. The only marker would be maybe just a physiological sinus bradycardia. The second degree type 1 is where there is progressive slowing of the conduction. So the next beat or the P wave groups with the previous one, and then there is a sudden absence of P wave. So that's like a Wenke-Back phenomenon. And then you have the second degree type 2, where you have just intermittently misfiring or non-firing of the P waves. And then you have, of course, complete absence of P waves in the ECG and just a junctional rhythm, which is called a sinus arrest or a complete junctional escape. Now, this is the entity, but when do you come to know? So when you're looking at an ECG and you have a normal sinus rhythm, and then you have a pause where the next P wave comes more than 2 or 3 seconds, that's a significant sinus pause if the patient has had symptoms. If the patient has had no symptoms, this pause, means the beat coming after 6 seconds, is considered to be pathological. This is important for us to understand because you can have pauses below 2 seconds and you can do nothing about it and patient will be fine. Of course, then you have something called as chronotropic incompetence, which is when you make the patient run on a treadmill or dobutamine, his target heart rates doesn't reach even 80% of what his targets are. And that is a form of sinus node dysfunction. That means the disease is not able to cope up with the increased demands. And of course, then you have tachycardia bradycardia syndrome, where you have sinus bradycardia or pause, which alternates with atrial fibrillation or atrial tachycardia, which is the most common presentation. So I'm sure by this time you would be considering as to why did we even call Malav for a talk, because he's made it even more confusing. So I'll make it really simple for you. Sinus bradycardia, chronotropic incompetence, and the atrial tachycardias are the usual clinical manifestations which the patient comes to you. Sinus pause and sinus arrest is what you will see in the ECG, which suggests that there is a sinus nodal impulse formation problem. The impulse is not formed at all. Whereas an exit block just tells you that the sinus node is doing its work, but it's not able to push it into the atrium, a propagation problem. Again, once you have diagnosed a patient with sinus node dysfunction, ruled out a lot of reversible causes, including OSA, and you're sure that the patient has had symptoms and he's come in an ER with an emergency, you treat it like any other acute treatment of bradycardia. Then you consider whether the patient needs a pacemaker and then whether it needs a dual chamber or a single chamber. So now, not going much into the theory, let's get to the cases. Now we are going to do just cases. I'm going to show you a few ECGs, and we're going to discuss real life scenarios which I've come and encountered during my practice. So this is a 70-year-old lady, ischemic heart disease in 2009, diabetic, hypertensive, COPD, asthma overlap with a mild OSA, already had an underlying rheumatic heart disease which was conserved, progressive MS, didn't require surgery. She's come to you with NYHA3 dyspnea, PND, recurrent, rapid, irregular palpitations, and recurrent episodes of giddiness and presyncope for the last 2 years. And she's been on diuretics and she's not doing well. Pulmonologist has said everything is fine from his end. And she's not a hypotensive patient at all, but we are not able to understand this. So we are really looking at something related to the rhythm. So this is her clinical evaluation, and you can see that there is a significant pulse apex deficit, and pressures are okay, but the JVP is a little elevated, and she has little early heart failure symptoms. This was her ECG. Now, very interestingly, if you see the ECG is showing, okay, there's sinus bradycardia 50, she's on a beta blocker, she must be on a beta blocker. I don't know, but we are not able to explain this problem at all. Her echo is fine. Take my word for it. This echo is okay. She has okay size valve. She doesn't have much of MR. She doesn't have much of pH. Also mild to moderate pH, and LV function is fine. That's when we get a Holter done. And this is what we find. You see this chaotic P waves here, marching in and out, irregular RR, and really sawtoothing in some of the ECG. So this is like a coarse atrial flutter or a fibrillation, which is usual with dilated LAs and rheumatic heart disease. And then imagine just here, there is a long pause, and then there is a sinus bradycardia going on. So this is like a long AF to sinus conversion pause. And it's a really long one, 2 to 3 seconds, and this could explain a presyncope. Imagine the heart rates being around 120 and then suddenly going down by 60, both being in the normal range, but the drop is almost 100%. So this patient had tachycardia bradycardia syndrome. Now, we treated her heart failure, we continued her SAPT statins and anticoagulation. The dilemma was, she needs beta blockers for IHD and her atrial fibrillation. She has significant bradycardia with that, and she is going to be using beta 2 agonists for her asthma COPD, which will aggravate the AN. Now, what do we do in such patients? This is a tightrope to walk. It's between the devil and the deep blue sea. So here, in such situations, we have to take a drastic step. Now, this patient's AF could not be treated by the usual means of ablation and all that. So what we do is we intentionally put the patient on a pacemaker, and we did something called as a conduction system pacing. So we placed the right-sided lead at a specific location in the septum. So we are able to get a very narrow QRS and a very physiological pacing QRS is there to avoid pacing-induced heart failure in future. And then we intentionally go and destroy the AV node that we discussed before, either the penetrating part or the compact node, and we destroy it so that the conduction between the atrium and the ventricle is now taken over by the pacemaker. Now, this is a very new concept, very old but a newly understood concept, where in atrial fibrillation you have irregular heart rates and you have fast heart rates. So you have irregulopathy, as it is called. So irregular heart rates make your pumping of the atrium really, really bad, and that's why the atrial kick goes away and patients become difficult to manage. So when you give them a AV nodal ablation, the lower rate, the ventricles pace regularly and really nicely, and then that leads to reduction in heart failure symptoms, and the AF gets confined to the atria. So this is not my first option, but given this patient who is really comorbid, I think this is a good option for this patient. And of course, it has societal guideline recommendations now for such patients as a last option. Now, this is what we did. Now, if you look at this really nice, narrow, neat QRS, and the patient's doing very well for the last 3 years now, out of heart failure and carrying on with the routine life. And this is what we did. We offered her a conduction system, left bundle branch area pacing, where if I don't show you the pacing spikes, you would say the patient's in his own rhythm. And this we are able to achieve today with the hardware that we already have. Now, this is another case, a 65-year-old male diabetic hypertensive, severe OSA on CPAP, 2 episodes of syncope in the last 6 months, and multiple pre-syncopal episodes. Everything else was normal. So again, if you look at the ECG now, I have put red lines where the P waves are, and you can see that the last 3 P waves tend to be grouping, and then there is a loss. So this is a sinus pause of almost 2.5 seconds with the prior grouping. So this is the type 1 second degree SA nodal exit block that we discussed about. So of course, in this patient, since he had syncope, no other reversible factors, not on beta blockers, patient needs a pacemaker. Now, the third case is a 70-year-old male who's a retired colonel, hypertensive, normal coronaries, just coming with pre-syncope and reduced effort tolerance. Now, we need to be sure that this patient is a colonel, so he was retired, so he was very active, and he says, "Doctor, I'm not able to run now." Otherwise, he's fine. So, clinical evaluation showed a aortic valve murmur, and the echo showed moderate calcific AS, no AR, normal LV function. Again, the ECG shows that if you can see here on your left, you can see that there is a PQRS, and then there is a long pause, no grouping. So this is basically, again, he had a Holter fortunately done before, shows a really long pause of 4 seconds. So this was you can make out that this is the reason for his symptoms. This patient again is a type 2 second degree sinoatrial exit block. There was no question about not offering this patient a pacemaker. He needed a pacemaker, a dual chamber pacemaker, and that would make life really well for him. This is another case, is a 72-year-old male diabetic hypertensive, PTCA done to RCA 25 years back. He has Parkinson's, but according to his neurologist, he's absolutely fine. There is no progression of the disease for the last 5 years, and he's able to do independent activities on his own. Now, he's come to you with exertional giddiness and pre-syncope and an episode of syncope on the way to the ER, and almost had a head injury. Now, he has bradycardia and his echo is fine. So, again, now take a moment to see this ECG and just see, on the face of it, this ECG looks just sinus bradycardia, right? But I need you to look at this and this QRS and see the difference between the two. These are the only QRSs which have a preceding P wave. All others have no P wave before them. So this is basically a sinus arrest. The sinus node is not functioning at all. And this is the so-called third degree sinoatrial block, or a sinus arrest. And this is the Holter which was done of the same patient. And very beautifully, if you can see here, so many long pauses. And this one is a sinus capture. You can see a P wave, and this has no sinus P wave preceding. It's the AV node which has taken over. It's a junctional escape. So this patient had a symptomatic third degree sinoatrial exit block, again needed a pacemaker. So this is another very interesting patient. 74-year-old diabetic hypertensive, ischemic heart disease, multivessel PCI done, severe AS, underwent a CABG and an AVR in 2018, coming to you with effort intolerance and fatigue and weakness. Mind you, all these patients, the usual hypothyroidism, iron deficiency have been ruled out. So we are not looking at those as a parameter. All those things we need to do in the background, even if we have not addressed to that before. And you may address to those problems also. Now this ECG shows again sinus bradycardia, rates of 40-50. The dilemma is that he needs beta blockers for his comorbidities. And imagine at very low dose also he's having symptoms and so much of bradycardia. So we need to differentiate whether this is a pathological phenomenon or it's a physiological phenomenon. And this is where an exercise stress test or a dobutamine stress test is very helpful because you're putting the patient to stress. Now, we did a dobutamine stress because we wanted to look at the valve status also. What we found is that there was a blunted chronotropic response to dobutamine, and the valve and the ischemia were not inducible. So he didn't have any other problems. So the diagnosis was that this patient has symptomatic sinus bradycardia and chronotropic incompetence. Because of his symptoms and because his requirement of beta blockers was there, we decided to offer him a pacemaker, and he's doing well. So this is in summary of the various forms of sinoatrial blocks that we discussed. And this cartoon really helps us understand what we have already discussed. Now coming very quickly to the AV block, it's an easier entity to discuss and to understand and to diagnose. You have to look for AVP and QRS relation. A QRS duration, if you have a P wave and don't have a QRS, that's an AV block. If you don't have a P wave at all, it's a sinus nodal problem. So that is what we need to look at. Then the QRS duration, which is in escape, tells you what is the site of the block. So if it's a broad QRS, it's generally a infranodal problem. A symptom rhythm correlation is required for the first degree and the Wenckebachs, but not always required for the higher degrees of AV block. And of course, asymptomatic high-grade AV blocks, regardless of their severity, need a pacemaker. So this is a 69-year-old female hypertensive who had good effort tolerance, presents to you for a routine evaluation, and she's been on atenolol for hypertension. She's absolutely fine, and this is the ECG where I put down the P and the QRS intervals for you, and it's about 300 milliseconds. She's not symptomatic at all, and subjected to a treadmill, Holter, everything was normal. So this is just a first degree AV block. It generally happens. Could be a normal variant. It could be because of medications. It could be in other patients because of a heightened vagal tone. And in most cases, it doesn't need any particular treatment unless you have a very significant symptom rhythm correlation, maybe a syncope which you are not able to explain. They generally would do well without a PPI also. This is another patient who is 80 years old with fatigue and uneasiness, no syncope. He was managed with his physician, and his echo showed HFpEF. He underwent a Holter and came to you with this. If you look at the ECG here and the Holter on the right, so if you see there is, I would look at the last complex first. So this PR duration is the shortest. And here if you see this one, it progressively has been increasing. And then one P wave is blocked. It's not going. So this is very typical of a Wenckebach phenomena. I would look to understand between a type 2 and a type 1 second degree AV block. I would look at the escape complex. If you have very short PR here and this PR is long, that's a Wenckebach. If this PR interval remains constant and the P wave is just getting not conducted down, that's a second degree AV block, the higher form of the AV block. So here again, it can be seen on this Holter, the similar phenomena. And so this is basically a second degree type 1 or a Wenckebach. It is because of an intermittent AV block at the AV node or a supraisian or intraisian disease. It is progressive fatigue of the AV nodes cells. It can be physiological when you have atrial flutter or a fibrillation or a tachycardia. It may rarely need intervention against strong symptom rhythm correlation where you have no other reason. On a given case, we can consider a pacemaker. Now, this is a 59-year-old male with syncope and structural normal heart. No prizes to understand what this is. If you were to just see here, there are two P waves, and then there is a QRS. So this is 2:1 or second degree type 2 AV block. And if you have more than 3:1 or a 4:1 AV conduction, it's called a high-grade AV block. Now, this is because of intermittent abrupt infranodal conduction block. So everything below the AV node. It could be if the escape is below the AV node, it is a broad QRS escape. If it's in the his or the penetrating portion, it's a narrow QRS. A broad QRS is a very pathological sign. He needs a temporary pacemaker to avoid death. Of course, this patient needs a pacemaker regardless. Now, this is a very interesting ECG. You have a 74-year-old diabetic and a hypertensive, HFpEF, normal LV function, unwitnessed syncope 6 months ago. He presents with worsening dyspnea. Now, the patient's seen by your resident and he finds a very deceivingly normal ECG, which he shares with you. And if you see here, the patient has a right bundle branch block on the chest leads and a left bundle branch block on the limb leads. So this is what we call as a masquerading bundle branch block with a PR interval first degree AV block. So this is a very strong harbinger of complete heart block happening in the next short 6 month duration with a very high chance of mortality if you don't treat. So the risk of progression is close to 60% over the next 4 years. And there is this denotes there is significant conduction system fibrosis of the left bundle branch. This patient needs a pacemaker even if there is no documented bradycardia. Again, this is a very typical patient, 85-year-old lady with extreme fatigue and syncope, and you can see there is no relation to the P and the QRS, and the P waves are also slow. So it's a complete heart block, which is again straight up needs a pacemaker, since the patient is in a complete heart block with a syncope. So again, the AV block spectrum is diverse as we have already discussed, and in this cartoon you can see the entire range of AV blocks that we have discussed. So to conclude, clinical evaluation and ECGs are cornerstone of diagnosis in arrhythmia management and bradycardias. Symptom rhythm correlation is vital for sinus node dysfunction and the earlier grades of AV block, namely the first degree AV block and Menkibach. A two-pronged approach of pacing and comorbidity correction is the rule for patients with sinus node dysfunction, and high-grade AV blocks need intervention at the earliest. Thank you for your kind attention.
So nicely taken, sir. Very good, sir. Thank you. There are some questions, sir.
Sure.
Somebody has asked, Dr. Vinay Desai has asked, 57 male as PSVT occasional, what are the chances of having stroke, CVA, no atrial fibrillation? Can I avoid radio frequency ablation therapy?
Okay, so PSVT again is a slightly diverse entity. If you are dealing with AV nodal reentrant tachycardias or AV NRTs, which are the most common forms of PSVTs, or you're dealing with the concealed left lateral pathways, which is the second most common. So in these subset of patients, they have normal hearts. The risk of stroke is not there if they don't have EV. The risk of mortality per se with sinus node dysfunction is also not there. The problem is these patients have very fast heart rates, 100, 200, 250. They can go syncopal. They need multiple ER visits. And that is the reason why a radio frequency ablation is offered to them as a first option, because beta blockers or calcium channel blockers have only 50% success of stopping these episodes. So a radio frequency ablation as a procedure, we will have a 95 to 99% success with a 1% chance of recurrence in the first 6 months. If it doesn't come in the first 6 months, generally it doesn't come for these two arrhythmias. So
Okay,
between the two, we would offer this. But yes, beta blockers can always be started till we take a decision.
Okay, sir. So Dr. Mahmood Merchant has said it's excellent case presentation. Well taken. RTS, congratulations, sir. There's one more question. Explain about the pre-syncope and syncope, how to differentiate clinically.
Okay, so if the patient is coming to you with a history of fall, and you sit down with the patient, you ask him what happened exactly. So he says, I was going to the bathroom or I was sitting, and I just fell down. The question that you have to ask them is, were you aware that you fall down? That somebody helped you? So if they were not aware and they were found on the floor and they were absolutely fine, the very next second, and they didn't have any other problems, no confusion, no abnormal movements. That's a typical cardiac syncope. Whereas it differentiates it from the seizure also. Whereas pre-syncope is when the patient really feels giddy and is about to become unconscious.
Dr. Gentilal sir has asked difference between AV-RT and AV-NRT.
Yes. So that is what I discussed before. When you have a abnormal circuit around the AV node, anatomically speaking, that's a AV nodal reentrant tachycardia. AV-RT is a WPW without a manifest pre-excitation. It is an accessory pathway anywhere else across the atrioventricular axis.
Okay, sir. Sir, what are the complications of dilated LA?
So one of the biggest complications of a dilated LA is that you will have a risk of stroke as the atrial fibrillation rate goes up. There will be settling of blood in the atrium and causing clotting and embolic phenomena. The other is really huge LAs sometimes can compress the esophagus and they have a sort of dysphagia which goes away after surgery. And very rarely we have seen patients with hoarseness because of the left recurrent angina. Extremely rare, but seen in rheumatic patients.
Okay, sir. Sir, Dr. Amit Thakkar has asked, please put the cartoon of different degree of sinus bradycardia again.
Sure.
And it's just, Doctor, many thanks, sir. Very lucid and comprehensive session, sir.
Thank you, sir.
I think that's all, sir.
Sir, sinus tachycardia has to be treated or not to be treated? Sinus tachycardia on ECG?
An extremely pertinent question, sir. If you have, I would give you a very non-controversial answer. If the patient has symptoms of, say, for example, patients come to you with fever. Patients come to you with not always fever, but looks pale clinically. The sinus tachycardia will help you locate systemic illnesses very well. I would seldom treat it with a beta blocker, but it helps me understand something's really wrong, which we know for ages that the pulse rate going up and there is blood loss or whatever. So it helps me understand that. I would not be in a hurry to treat a sinus tachycardia at all. But now, given this, today we have a very minute subset of young adults or young
people,
adults, with inappropriate sinus tachycardia, which may be offered ablation. But I think I would take it with a sack of salt. It's an overdiagnosed entity, but it is there. But I would say I would look at the entire systemic spectrum, anxiety, everything, treat all of that, and then that 0.1% we may offer them ablation.
Okay, sir. So there's one more. Dr. Mahmood has asked, when the patient expired due to various other causes, it is advisable to remove the pacemaker. Are there any new pacemaker without wiring?
Yes. So the removal of pacemaker is only for two reasons. One is that we are able to utilize that donated pacemaker. We used to initially implant it in the patients after ETOing them for non-affording patients. Nowadays, we have found a different use to it. So when patients become infected for whatever reason, and we have to remove the pacemaker which is already implanted, we put a jugular access, we put a permanent pacing lead, and we connect this donated pacemaker then. So with that, the patient can be shifted to the room, become fit for a permanent pacemaker at a later date. So for our utilization, if you want to remove the pacemaker, is fine. Now, it is likely to burst in a crematorium inside. So it's not going to be a threat to anybody. If you're burying the patient, then it doesn't matter. So, but why let a good hardware go to waste? Like we donate organs. If the family wishes to, we can. The
It's a
second
good
is,
thing.
second thing is we have leadless pacemakers available in this city now. Both the leading companies have it. The third company is going to get it this year. Now we have separate pacemakers for the upper and the lower chambers, atrium and the ventricle also. The indications of a leadless pacemaker for me are very clear. The most important indication is a patient who does not have a venous access or has a pacemaker and got infected, so I can't put a traditional pacemaker, or the patient's on a dialysis and requires a pacemaker because again the risk of infection is too great. Now, whether you can offer it to a 92-year-old who is really frail, yes, that would be my extended indication. But yes, this
Okay.
thing is available for use in India, in Mumbai, for the last 4 years now.
Yes, so the Dr. G.R. Nagabhusana has asked, asymptomatic RBB with a left axis deviation, any problem, sir?
So this would actually be considered to be a bifascicular block as per our definition. Now, if the patient's asymptomatic and patient has no other problems, a cautious follow-up is all that is required. If they develop symptoms, I wouldn't wait for a pacemaker.
So what is
Dr.
the
Amit
significance?
Thakkar has asked, can we give ivabradine in sinus tachycardia?
Yeah, so the only indication possibly of ivabradine apart from heart failure is sinus tachycardia.
Okay, sir. Yes, sir. Dolakia, sir. Any question?
What is significance of single chamber and dual chamber
Right.
pacemakers?
So the traditional data has been very clear. Now, normally you have atrium contracting first and ventricular contracting afterwards in our heart physiologically. That allows the ventricles to fill in and pump at the same time. So why we give a dual chamber to everybody is if you maintain this AV synchrony, the risk of pacing induced heart failure is minimized. Simple single chamber right-sided pacing is anyway the most non-physiological means of pacing because normally if you look at the physiology, the septum activates from the left to the right and then it goes from apex to base. When you put a RV lead, you are anyway destroying this problem. So we need to at least maintain the atrial synchrony to avoid heart failure. Now, of course, we place the right ventricular lead also near the left bundle by screwing it deep at a specific location. That's what I showed in one of the cases. So that brings down the 10% rate of pacing induced cardiomyopathy in a dual chamber pacemaker to even less. But the reason of AV synchrony, even in a sinus node or AF patient, is a lot of AF patients would have spent their time in sinus rhythm without we knowing because we don't monitor them so frequently. So at least when they are in sinus rhythm or with your quadrant they go in sinus rhythm, you are able to give them a AV synchrony. So heart failure is reduced in such patients.
Why the people want to adjustment every few days or few months in pacemaker?
Okay, so
What adjustment there?
Correct. So simple pacemaker seldom needs adjustments. We check the pacemaker parameters to ensure that the leads are stabilized and they are good to go for all activities. Second is sometimes when we put a particular parameter and say HFpEF, most of the patients may be HFpEF. If we keep the atrioventricular delay is now artificially programmed by the pacemaker. So if it is really short, then when the atrium is still contracting and the AV valves are open, the ventricular may start contracting and cause mitral regurgitation. So in certain patients, we may increase the AV delay based on symptoms.
Yeah.
Any more questions, sir?
Yeah, fine.
Good evening to all. We have come to the close of the insightful of 304 webinar. It is my privilege to deliver the vote of thanks on behalf of General Practice Association and in collaboration with the Jaslok Hospital Research Center. I sincerely thank our speaker, Dr. Malav Jhala, for a wonderful, enlightening session, and your thoughts have truly enriched our understanding to the topic. I also like to thank all our participants for joining online and making the webinar 304 a success through your presence and interaction. A big thank to our organizer team, Dr. B.K. Dolakia sir, Dr. Bharat Bhatt sir, Dr. Mahmood A. Merchant sir, and our technical team, Dr. Mr. Avinash and Pranav. Thanks once again, and hope to meet you all in the next webinar. Thank you, sir.
Thank you.